Welcome to the Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flam, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Welcome to the Seasoned Sonographer. Today, we're going to be talking about mastering the first trimester ultrasound, guidelines, image optimization, pathology, and challenges. Who is this episode for? It's for sonographers, students, and providers using ultrasound in early pregnancy assessment and in that first trimester vaginal ultrasound. Why does the first trimester ultrasound matter? It is crucial for confirming pregnancy, viability, location, and dating. First trimester ultrasound is important for establishing that gestational age and having a good solid due date or EDD, especially for tracking the pregnancy growth later on in the third trimester. A lot of times, if the patient has any comorbidities like chronic hypertension, gestational diabetes, pre-existing diabetes, and even obesity is an indicator for those third trimester growth scans. So once you establish that accurate due date in that first trimester, you have a way to track that growth. And we're looking for, when you have those comorbidities, we're looking for fetal growth restriction, large for gestational age, or macrosomia. So that's very important for fetal monitoring later on in the pregnancy. You can make sure that first trimester transvaginal ultrasound EDD matches with that last menstrual period that the patient gives you within 5 to 7 days, and that's depending on the gestational age when you look at the chart. If it doesn't match, then you will go by the transvaginal ultrasound due date. That transvaginal ultrasound also helps detect any early abnormalities that you might be able to see, allowing for a timely intervention. It's a commonly performed scan, but it comes with some unique challenges, and it does require some skill and experience. I'll talk about those challenges later on in the show. Some of the indications for performing a first trimester ultrasound are obviously dating, confirming the intrauterine pregnancy and viability, ruling out any ectopic. If the patient's had bleeding or pain, you want to get a first trimester ultrasound and see what's going on there. You can assess for multiple gestation, twins, triplets, evaluation of a suspected pregnancy failure. Perhaps the gestational sac might be low in the lower uterine segment, a miscarriage in process, or it might be irregular. You want to follow up after any IVF or assisted reproduction after they're released. A lot of times from their reproductive endocrinologist, the providers will want a follow-up scan in our office or at the hospital, again, to confirm that viability after they've been released. Evaluate the maternal pelvic anatomy for any fibroids, ovarian cysts, or any congenital anomalies. Maybe there's a bicornate uterus or a heart-shaped uterus or septate uterus. Let's talk about some of the AIUM guidelines for first trimester ultrasound. These are required images and documentation criteria. You must document gestational sac, yolk sac, fetal polar embryo, cardiac activity, amnion and chorion, and adnexal and uterus assessment. Let's break each one of these down and talk a little bit about them. The gestational sac. When you're looking at the gestational sac, you want to make sure that it's within that endometrium, high up within that cavity. The shape and the contour should be round and smooth. You should see that decidual cast or decidual ring around it. If you do not see a fetal pole and you see the gestational sac only, you want to measure and get the mean sac diameter of that sac. In all three dimensions, you'll measure that sac. When you're looking at the sac, is there a yolk sac in it? What does that yolk sac look like? What size is it? What shape is it? It should be round, smooth, thick. If it's greater than 6 millimeters in diameter, inner to inner, then it's hydropic or enlarged. An enlarged yolk sac is typically thin and it looks enlarged, and sometimes they can even be calcified, like a little echogenic round area. So that could be an indicator of a failing pregnancy. Embryos and fetal poles, you want to measure those, get a good crown rump length. The normal rate of growth is about 1 millimeter a day, but when you're getting that crown rump length, make sure you're lengthening that out to its longest point. Make sure that you're twisting and turning that probe a little bit, getting the very best measurement of that crown rump length, and measure that. Measure it 2 or 3 times to get a good average and document all of that. The cardiac activity, we want to document using M mode. It's not recommended that you use the pulse wave Doppler in the first trimester. In fact, I use M mode throughout the whole pregnancy to document heart rate. A normal heart rate is about 100 to 160 beats a minute. Some resources say 120 to 180, but I find that in that first trimester, very early, like 6 weeks, it is around 100, a little over 100. Less than 100 is concerning for a failing pregnancy. You want to look at that amnion around the baby and yolk sac. You want to look at its integrity and look at the chorion, the larger chorionic sac. Those usually fuse around 12 weeks. Then you want to look at the adnexal structures and uterine assessment. You want to look for, in the adnexa, a corpus luteum, a cyst, perhaps some sort of mass. But once you see that intrauterine pregnancy and you see a cyst on the ovary, it's likely the corpus luteum. You can put that color Doppler vascular flow on there and see that classic ring of fire to confirm that that is the corpus luteum. Those can appear to be hemorrhagic. They can be collapsed with irregular borders, or they can be totally simple looking and cystic. So if they're having pain on one side or the other, it could be due to the corpus luteum cyst. You want to check for any free fluid that's suggestive of any rupture or hemorrhage. You want to evaluate for fibroids that could affect the pregnancy based on their location. Whenever I look at fibroids and see fibroids, I make sure to note in my report, the preliminary report, the location subserosal, submucosal, or intramural, just so the provider has an idea of where they are and how they may affect the pregnancy. Optimizing those images, you want to always be sure to adjust your depth, gain, and focus. You want your area of interest to be in the center of the sector. You want your focus to be right there in the center where your area of interest is. And you want your depth adjusted so that you don't have a lot of unnecessary information in that far field. You don't want your area of interest really superior in that sector. You want it right in the middle. We don't need to see all that bowel and everything behind that uterus. We just want it set good enough so you can see that posterior wall of the uterus, any fluid in the cul-de-sac that might be there. So always be sure to adjust your settings so that you can see the fundus and slightly posterior. Put your area of interest in the middle. The best approach for first trimester dating scans is transvaginal. It provides a better resolution It's ideal for the pregnancies that are less than 10 weeks. You can see, after 10 weeks, you can see pretty good abdominally, depending on maternal habitus, but we always just look vaginally, cut to the chase, and start vaginally. It just provides a better, more high quality image, better detail when you're looking at that cardiac activity, the yolk sac, more crisp edges on that crown rump length. That high frequency transvaginal probe is usually 5 to 9 megahertz, and that's just providing great detailed imaging. When you're looking at the first trimester pregnancy, you're also evaluating for any abnormal findings, any pathology, an irregular shape of the gestational sac, or a thin gestational sac wall may be suggestive of poor viability. No yolk sac or fetal pole when the mean sac diameter is greater than 25 millimeters is very concerning for pregnancy failure. The pregnancy failure guidelines based on AIUM are a crown rump length greater than or equal to 7 millimeters with no cardiac activity, or a mean sac diameter greater than 20 or greater than or equal to 25 millimeters without an embryo. Anytime you see a fetal pole, really, you should see cardiac activity. An absence of an embryo with a heartbeat about 2 weeks after you do a scan showing a gestational sac and yolk sac is indicative of a likely failing pregnancy. An enlarged yolk sac greater than 6 millimeters without an embryo is concerning. Subchorionic hemorrhages, man, those are tricky. We see them a lot. They don't necessarily mean the patient is going to have a failed pregnancy. Sometimes the patient is symptomatic, sometimes not. Their appearance is hypoechoic or anechoic, kind of around that gestational sac. If it is large, if it's a large subchorionic hemorrhage, it's more concerning for pregnancy loss. But if they're smaller, we see those a lot, and the pregnancies more than likely continue. Some patients have problems and symptoms and some don't. They might have mild cramping, they might have spotting, they might have bleeding. We usually don't follow up on those subchorionic hemorrhages if they're asymptomatic. If they're symptomatic, we like to look again just to prove viability one more time. Molar pregnancy, that snowstorm or hydropic villi, cystic areas, tiny cystic areas within that endometrium in a molar pregnancy, there's no fetal pole. The endometrium is just full of those cystic areas. And a partial mole, sometimes that can contain a fetal pole, even a viable fetal pole with a heartbeat can be seen. Those pregnancies do likely fail. Ectopic pregnancies, there's no intrauterine pregnancy, and that if there's no intrauterine pregnancy and that quantitative HCG is high enough that you should be seeing one, 1800 to 2000, you should be seeing an intrauterine sac with that decidual cast around it, with that double decidual sign. If you do not see that, then it could be an ectopic pregnancy. So you want to look out to the adnexa. You want to look for a mass. You want to look for a sac. If they're far enough along, sometimes you can see a fetal pole with a heartbeat in the adnexa. A lot of times the ectopic pregnancy is a mass. It will show up as an echogenic mass, sometimes with an anechoic center. You put that color vascular flow on that, and it should light up that ring of fire, which is a classic confirmation of an ectopic pregnancy, not to be confused with the corpus luteum, because you've already seen that there is no intrauterine pregnancy. You'll look for any free fluid in the pelvis, indicating possible rupture. Some patients have mild symptoms and some patients have intense symptoms, cramping, bleeding. There can be a pseudo-sac where you see some blood inside the uterus, or a small round anechoic area that does not have that decidual cast. That is indicated. That is indicative of an ectopic pregnancy. You better go look for it and try and find it. I have to tell you about this story that happened fairly recently. We had a patient that went to the ER. I guess she was having some mild cramping and spotting. And she went to the ER and they did an ultrasound and they could not find an intrauterine pregnancy. Her quantitative HCG was in the thousands. And so obviously it was an ectopic. So the physician took her to surgery to remove the ectopic pregnancy, and there was no ectopic to be found. She followed up in our office. It was to find the intrauterine pregnancy or a possible molar pregnancy or figure out what was going on. And it was just a normal dating scan. I put the vaginal probe in. I adjusted my depth, my gain and focus. Her uterus was a little retroverted, but I was able to see the fundus of that uterus, an intrauterine sac, yolk sac, fetal pole, heartbeat, all at about between 8 and 9 weeks. And we looked at those images. She pulled up the images from the hospital, and the image was a picture of the cervix. And that's all. There was just images of the cervix. The tech had not adjusted the depth so that they could see the entire uterus, and they thought the cervix was the uterus, I guess. So no intrauterine pregnancy could be seen. So again, if you can't find that pregnancy, try harder. Adjust your depth, adjust your focus and gain. Make a big effort to find it. If the quantitative HCG is in the thousands, it's in there. You need to make a big effort to find it. Adjust that depth. Make sure you're seeing that fundus of the uterus and looking inside that uterus. Some of the challenges in first trimester ultrasound include maternal body habitus. Again, it can be hard. You have to adjust that depth. You have to use a little more pressure. Definitely use the transvaginal approach because your transabdominal is going to be very limited. You need to distinguish that pseudosac from a true intrauterine pregnancy. Make sure you're seeing that double decidual sign. If you see a sac with no decidual cast around it, no yolk sac or embryo, and it's irregular, it's probably a pseudosac, a pseudogestational sac. You always want to make sure that you're measuring that crown rump length accurately. Again, make sure it's elongated and you're getting both ends. You want it in a neutral position. Later on, like 11 to 12 weeks, they can curl up and flex, and you want to make sure that you get the measurement when they're in a neutral position, no flexion and no extension. When you find a fetal demise or a failing pregnancy, be sure to very delicately and gently communicate that with your patient. Be sensitive when you're discussing early pregnancy loss. There are times when there's just uncertain viability, and you can express that follow-up is necessary, that sometimes it just takes time to confirm either whether it's just an early pregnancy and we can't see it, or whether it is an abnormal pregnancy. Each department has its own criteria and rules, if you will, for what the sonographer can say and do. So make sure you're familiar with how much you can say to the patient without compromising any policies. The vaginal ultrasound, it's just an amazing tool. It just sets the stage for the rest of the pregnancy when you can confirm that viability and get a due date and move forward. Final thoughts. The AIUM guidelines should be followed. Take your measurements, document those, optimize your image settings, your depth, gain, and focus. Area of interest right in the middle of that sector. Recognize some of the first trimester pathologies, when to raise concern, when to get your provider or talk to the radiologist. Troubleshoot some challenges to improve scan quality. Try harder to make your scan the best it can be. Thank you so much for joining me for this episode of the Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to the Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sonotechniques Academy. Explore more educational resources on the Sonotechniques Academy app, or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of the Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.